Hello, everyone. We are just waiting for people to filter in from the waiting room, and we will begin in just a minute. Hello and welcome to those who've just joined. We will begin in just a minute. We can see quite a few people still filtering in from the waiting room. Okay, let me get started. There are already over 400 people online, which is amazing. So hello, and on behalf of WHO and Jhpiego, it is my absolute pleasure to welcome you all to today's Global PrEP Network webinar on applying the PrEP Provider Training Toolkit to supporting clinical decision making. I am Heather Marie Schmidt, and I am with both WHO and UNAIDS, and I am welcoming you to this webinar this morning. So just before we get started, some points on housekeeping. So the webinar will be recorded and slides will be sent to people who registered after the webinar. Please, we welcome your questions. Ask questions using the Q&A function. There is also an option if you like a question that somebody else has asked, please use the ability to give it a thumbs up and upvote it. So we know that this is an important question to answer. We, everybody on this webinar, will do our best to answer as many questions as we can, either by replying in the Q&A or through the Q&A at the end of this webinar, so answering live. Today, we also have an AI-assisted closed captions and translation function. To turn this on, go to the captions and translations button along the bottom screen. There's a ribbon there. Turn on translation and select the language that you would like to use. And finally, we will also have polls and quizzes during the webinar. These will pop up on your screen and you will have about 20 to 30 seconds to answer. Please do participate. We really want to hear from you. Participants have been muted because there are so many people on this webinar. Currently, there are over 500 people and the numbers are going up. So unfortunately, we don't have the ability for everybody to speak, but please do use the Q&A if you need to ask a question to us. So on the agenda today, we will have an overview of the WHO and Jhpiego training toolkit, which will be provided by Tigistu Amadou from Jhpiego. We will go through the principles of PrEP delivery, and that will be led by my colleague, Michelle Rodolph from WHO. Elizabeth Arungu from Jhpiego and myself will go through a case study about Amina and her journey of using PrEP and Lenacapavir. Finally, Elizabeth will also continue with adaptations for using this toolkit locally, which is an amazing opportunity for countries. And we will have a Q&A that will be moderated by Michelle, where we will respond to your questions. And so without further ado, let me hand over. Tiggy, over to you.
Thank you very much, Heather Mary. Greetings, everyone. So I'll start. I have only a few slides. as we expand the HIV prevention toolbox, healthcare providers, we believe, must stay ahead of new options and approaches, and that's exactly what this toolkit is designed to support. This toolkit is built to support clinicians in providing multiple PrEP methods, from oral PrEP to long-acting cabotegravir, the Piperine vaginal ring, and the newest addition, Lenacapavir. It is a comprehensive resource that translates global evidence and WHO guidance into practical, actionable steps for everyday clinical practice. Ultimately, it is meant to empower choice so clients can select the prevention options that best fit their lives. The toolkit is organized into 4 key modules, as you can see here, that follow the clinical journey of PrEP delivery. Starting in the first module from what each PrEP method is and how it works in the product formulation and evidence module, to how to assess who can benefit most in the eligibility and contraindications module, to a step-by-step guidance on how to initiate and deliver each product in the administration and dosing module, and finally on how to provide ongoing support, monitoring outcomes, and managing side effects on the follow-up and side effect module. And each module builds on the previous one, taking providers from foundational knowledge to client-centered service delivery. Next slide. We know that training needs vary across settings, so flexibility is built into this toolkit. It can be used for self-paced online learning or in-person classroom sessions or a hybrid approach. We have also included downloadable job aids and adaptable training materials to support facility-based mentorship, pre-service education, or just-in-time on-the-job training. And importantly, a mobile application complements the training, hopefully providing quick access to WHO guidelines, dosing calculators, and clinical decision support tools right at the point of care. Next slide. The toolkit and all its components, including the mobile apps, are freely available and designed for global adaptation, as you can see. With these resources, we believe we can accelerate the rollout of comprehensive PrEP services and bring us closer to our shared goal, ending HIV as a public health threat. So finally, before I transition, as you hear the details today from my colleagues, I encourage you to think about how this toolkit can be integrated, and there will be a discussion around that, into your national training strategies, if you will, pre-service curriculum, or continuing professional development efforts in service of your communities. And please do share feedback on how it can continue to evolve to meet provider needs in your own setting and in many different settings globally. So with that, I wanted to ask if all of you can really answer in the next 15 to 20 seconds what your role is. Thank you very much, everyone, for your answer and participation. Lots of healthcare providers, administrators, policymakers. So we have a range of practitioners in this group today. So please enjoy the deep dive with my colleagues. Next slide.
So hello, everyone. My name is Michelle Rodolph. I work with the World Health Organization in Geneva. I've been working in PrEP for a number of years now. If anyone was sent to the Teams meeting by accident, that was my fault. So my apologies for that. So I'm just going to give a very brief overview on PrEP and what it means from the WHO perspective. So next slide, please. So WHO recommends 4 PrEP products to prevent HIV acquisition. So the first since 2015 is oral PrEP containing TDF, followed by the Dpivirine vaginal ring. In 2022, long-acting injectable cabotegravir, and most recently, long-acting injectable Lenacapavir. And just as a note, not all PrEP products are available in all countries. So for the purpose of this training moving forward, please always refer to national policies and guidelines to determine which PrEP options are available locally. Next slide, please. So with sharing the most recent WHO recommendation on Lenacapavir, Lenacapavir was a first-in-class HIV-1 capsid inhibitor, subcutaneous injection administered every 6 months. It was approved by the US FDA in 2022 for the treatment of multi-drug resistant HIV in people living with HIV who are highly treatment experienced, and by the US FDA and by the European Medicine Agency in June and August of 2025 this year for HIV prevention. And to really clarify and specify for the purpose of this meeting, this webinar, WHO's recommendation on long-acting injectable Lenacapavir is for prevention only. WHO does not have a recommendation on injectable Lenacapavir for treatment at this moment. WHO recommends that long-acting injectable Lenacapavir be offered as an additional prevention choice for people at risk of HIV, or more appropriately, people who would benefit from receiving PrEP products as part of combination prevention approaches. Next slide. So Lenacapavir is managed and packaged in 2 different formulations. There's the liquid solution that's injected subcutaneously, and that's 2 injections at initiation continuation. And there's an oral pill taken by mouth. Now, at initiation, clients take 2 oral pills on day 1 and 2 oral pills on day 2. And by taking those 2 pills on days 1 and days 2, we call that the loading dose. Lenacapavir injection by itself will only start working within about 3 weeks, 3 to 4 weeks of those first 2 injections. By taking the 2 pills on days 1 and days 2, clients will have near immediate protection, with protection starting within 3 to 24 hours after taking those first 2 pills on day 1. Next slide. I also want to add in this presentation that WHO has a recommendation on HIV tests for starting continuing PrEP. Now, WHO currently has a recommendation for HIV self-testing for oral PrEP, the Dpivirine vaginal ring, and PEP, post-exposure prophylaxis. HIV self-testing may be used to deliver pre-exposure prophylaxis and PEP for initiation, reinitiation, and continuation. Now that is, as I said, at the moment, we don't have a recommendation on HIV self-testing for long-acting PrEP, but we do have a recommendation on using rapid diagnostic tests for initiating, continuing, and discontinuing long-acting injectable PrEP. And that really translates for countries to use their national algorithm for HIV testing as they use already. Next slide. So now PrEP use in pregnancy and breastfeeding. Oral PrEP, Dpivirine vaginal ring, CAB-LA, and LEN do not need to be discontinued during pregnancy and breastfeeding. If a woman is already using any one of these 4 products and becomes pregnant while using those products, there is no need to decrease the product that the woman's on. It is very important to balance the benefits of the harms when a woman's pregnant, meaning that a woman should not be risking HIV acquisition while pregnant. There's no dose adjustment required during pregnancy. And also now when someone becomes pregnant, the choice to initiate PrEP, has to be a discussion with the woman, the individual, and her healthcare provider. That does not mean that a person should not initiate PrEP when they become pregnant, but this is a rights-based healthcare decision between the individual and his or her provider. Next slide, please. And really, I want to emphasize here about choice. Offering choice in prevention in general and PrEP products can increase uptake, effective use, satisfaction, protection. The best product is one that someone wants to use and will use well. We've seen that choice is dynamic, choice changes over time, and what works today might not work tomorrow, but people should be afforded choice in making their prevention decisions. I am going to hand over to the next slide, where I'll hand over to Elizabeth Arungo from Jhpiego and Heather Marie Schmidt from UNAIDS and WHO, who will take us through the next session. Thank you so much for your attention.
Thank you, Michelle, and thank you everyone for joining this webinar. So our next section of the webinar is a case study that we're going to take you through between myself and Heather Marie. And the case study is a journey of this lady that we're going to call Amina. So Amina is a young woman. She isn't married, but she does have a partner whose status she does not know. She has one child and is actively trying for another child. She does not have any known illnesses. She has been using oral PrEP, but is concerned about daily pill taking, and she forgets to take her pills quite often. But she also values privacy and wants to have fewer clinic visits. So here's our question. Based on what you know, is Amina eligible for LEN? Please respond. Okay, we have 10 more seconds. Good. Okay. I need to close here. So I don't know what your response is, but Amina does need further evaluation. The information we have is not sufficient. It gives us some inkling as to what direction to go to, but she needs further evaluation. And so what steps should we take to assess whether a client is clinically eligible to start a PrEP product? There are multiple assessment steps that should be completed to determine such eligibility. And then once you have, and then some of these steps are common across PrEP products and some are product specific. But once a client comes in, says, I would like this product over the other, it is necessary for providers to ensure that that client is clinically eligible to use that product. And so for eligibility assessments that are common across any PrEP product, is that we really must do a HIV test and be sure that the client before us is HIV uninfected, so that they can receive PrEP. You also need to evaluate whether they have had possible exposure to HIV in the past 72 hours, which is a PEP assessment, in which case you would decide that you would have a determination that this client needs to go on PEP right now, rather than put them on PrEP. Also need to evaluate whether they have had acute HIV infection, whether they have acute HIV infection signs and symptoms. Have they had an exposure in the last 1 month? And are they manifesting signs and symptoms over the past 2 weeks that would be suggestive that they might have acquired HIV infection? In which case, then you would have a determination over, let's not do PrEP now and let us review their tests, defer assessments for PrEP. And then also check if they have any other medications that they are using that would interact with PrEP. Check if they have any comorbidities and determine whether they have any medication allergies that would interfere with their ability to use PrEP. So you do the assessment for the client before you, and you may have revealed contraindications to PrEP. Any product, PrEP product, is contraindicated in clients who have a HIV positive status or an inconclusive HIV status. They're contraindicated in people who have a high indication for PrEP, and contraindicated in people who have an allergic reaction to the PrEP product that they are proposing to use. And so let's look at some of the LEN-specific contraindications and considerations. And this would come in addition to what we have reviewed in the past, in the previous slides, regarding any PrEP product. So if you evaluate the client and find that you have a high suspicion of them having had a high suspicion of AHI, acute HIV infection, then you would advise the client to return in a month for HIV retesting, and you hold off evaluations for LEN eligibility at that point. You defer them and say, hey, we are going to review it in a month for HIV testing. Why this is important is that the potential risks and benefits for deferring or starting LEN would be made on a case-by-case basis with the client and the provider. And you would defer if you feel that the risks of potentially starting PrEP highly outweigh the benefits of using it, that this client is very likely to be seroconverting. And so the benefits of deferring PrEP initiation at that time would outweigh the benefits of starting PrEP. But during this 1 month that you have asked them to hold off, you need to consider alternative HIV prevention strategies that could be chosen to use this time, including use of the Dapivrin vaginal ring for those who are eligible. But remember that use of LEN for individuals living with HIV can result in development of viral drug resistance and therefore affecting their ability to respond to HIV treatment in the future. And so that's why you want to consider what is the benefit and what's the risk, what outweighs the other. Should we defer now, or is this something that would initiate? And that is a case-by-case discussion and decision between a client and their provider. And then what of medications? Are there medications that interact with LEN? So there are few drug-to-drug interactions and contraindications to using LEN with other medications. So there are labels. There's a regulatory label from US FDA, and there's a label from the EMA. The US FDA label, for instance, regarding antibiotics use, especially those for treatment of tuberculosis, the US FDA label permits use of Lenacapavir with TB drugs, but you would need to do some dose adjustments for the Lenacapavir doses. With EMA label, their instruction is that it is contraindicated to use. So we are evaluating this space, and I'm sure as things become clearer, WHO is going to give guidance on what's the best thing to do for clients who have TB at the point of initiating Lenacapavir. LEN is not expected to interact with other gender-affirming hormones based upon the evidence that we know now, that we have now. And then the other good thing about Lenacapavir is that there are no known comorbidities that contraindicate LEN use. So where in the past we have been careful and said we have to evaluate, renal functions, we have to evaluate liver functions and all these other things to rule out comorbidities, this is not routinely necessary for Lenacapavir. But it should be known that individuals with severe liver conditions, hepatic impairment, were not part of the Lenacapavir trials. And then as Michelle has just said about PrEP use in pregnancy, all PrEP products are considered safe and effective for use by pregnant and breastfeeding individuals, even though the evidence is much higher. The data we have is much more for TDF-based oral PrEP compared to the other methods. I think countries will provide guidance, national regulatory bodies will provide guidance on whether to give pregnant and breastfeeding people Lenacapavir in their countries and whether such testing is required. So you'll keep referring back to what your national policy says. But as WHO says, that it is safe and effective for pregnant and breastfeeding populations. And as you use the material, the training toolkit, you will see job aids as part of the resources. And this is an example of a job aid that you would use as a provider to help you understand and assess the client in front of you and what methods they can use, what options are available, what would be contraindications, what makes them eligible and not eligible. And these materials are available. So anyway, we go back to Amina. After counseling, we find that Amina and her provider decide that Lenacapavir would be a good choice for her if she's clinically eligible. So she tests HIV negative, she has no indication of PrEP, and there's no suspicion of acute HIV infection. She's taking oral PrEP, but she's not taking any other medications. And she has not had any allergic reactions to PrEP in the past. So hey, Amina is eligible for Lenacapavir, right? So the next question we have for you is, how do you initiate Amina on LEN? Please do your polling here as I hand over to Michelle, to Heather Marie to continue.
Thanks, Elizabeth. We'll just give you a little bit more time to answer this question. So about 1/3 of people on the call, on the webinar, have participated. We'll just wait for a few more answers to come in. Okay. And so move on to the next slide. The correct answer is 2 injections today and 2 pills today and 2 pills tomorrow. Sorry. Yes, there we go. And I have to say, about a quarter of you got this correct. So that is pretty good considering you're doing this training today. So to start Lenacapavir, the initiation regimen, as we call it, involves both injections and oral tablets, as you just saw. At this time, we don't have any evidence for an alternative dosing to start. So this is what you have to do. The initiation regimen is really important in terms of reaching adequate drug levels in a timely manner. So reducing that time to protection to the minimum amount so that you can be protected very fast, or clients can be protected very fast. Next slide, please. And this is what it looks like. So on day 0, this is the day probably that you had your HIV test, or the client has their HIV test. The provider can administer 2 Lenacapavir injections, and these are called Lenacapavir injection 1, initiation injection 1, and initiation injection 2. And the client takes 2 Lenacapavir pills, so 300 milligrams each, loading pills 1 and 2 by mouth, and is provided with 2 additional pills of 300 milligrams each to carry home. These are then taken on day 1, the next day, the day following the injection, by mouth. So they take those 2 days, so 2 pills. So perfect, next slide. So the whole regimen, the complete set of injections and tablets taken on time, are required to get and to achieve protection very quickly. So within 3 to 24 hours of taking those first 2 doses. So you know that you're going to be protected very quickly. So for example, if you took your initiation injections, your first injections on a Wednesday, and you took those initial loading, the oral loading dose, the first 2 tablets on Wednesday, took the second tablet on Thursday, by Friday, you're going to be protected, which is great. The first 2 oral loading doses, the ones that you take on that first day, are really important to provide protection quickly. The second 2 pills are really important to make sure that that protection lasts. Sorry, yeah, that slide. Without the oral loading dose, protection can take 3 or 4 weeks, for example. So these really do work together, and it's incredibly important. The injection ensures 6 months of continuous protection. So next slide. So then the next question is, when would Amina need to return for her follow-up visit? So I'll give you all about 30 seconds. Please try and answer as quickly as you can so that your answer can be registered. So your options are 1 month from today, 3 months from today, 6 months from today, or 1 year from today. Today being the day that she got her first injection. I feel like lots of people were definitely listening to me just now, because we do have almost 2/3 of people gave the correct answer, which was 6 months from today. So amazing, congratulations. So after starting LEN, follow-up injections are required every 26 weeks, or about 6 months, to maintain protection. There's no oral component, so no oral pills that are required for a follow-up injection that's administered on time. There is, however, a very short window for the injection to be administered on time. So that's 2 weeks before or 2 weeks after that scheduled follow-up injection. So between 24 and 28 weeks after that first injection. This means that it can be administered that 24 to 28 weeks and still be on time. But because of the tight injection window, it may be better for services to consider and for clients to consider booking an appointment that's slightly early. That means if things come up or people's life gets in the way, they're able to still attend their appointment before the 28-week cutoff. Next slide. This graph illustrates what is happening with Lenacapavir concentrations. And what we want to do is make sure that they stay above that horizontal line in blue, because this is keeping them at sufficient levels to ensure continued protection. And this is done and maintained if a client returns online. And as I mentioned, it's able to be maintained without oral dosing in the follow-up injections, but it is incredibly important to achieve that protection quickly, to make sure that those oral doses are taken by the client at the beginning. So when those initiation injections start. However, Amina has missed her appointment. Amina started Lenacapavir on the 1st of April and was scheduled to return 26 weeks later on the 30th of September. Unfortunately, she missed her scheduled appointment and returns to the clinic today, which is October 8th. So the 8th of October. We have another question for you. What should you do during Amina's visit today? Should you resume with her follow-up injections? Should you restart with the Lenacapavir initiation regimen? Or should you encourage her to switch to another PrEP method? And I'm going to hand over to Elizabeth now, who will take you through the answer in a minute.
Okay, we can give you a few more seconds. right. The correct answer for her is resume with LEN follow-up injections, because she only missed her injection within, was I think less than 2 months, less than 2 weeks. So the thing to note is that if a client misses a scheduled injection and wants to continue LEN, then they should return. We will advise clients to return to the site as soon as possible. Then the provider they meet needs to make the decision as to whether do we restart LEN with the initiation regimen, which is 2 injections plus 2 pills and then 2 pills the next day, or do we resume by administering the follow-up injections? And this is how you make the determination. It depends on the amount of time that has lapsed since the last injection. And we're determined to proceed as follows. If the time between their last injection and the time they show up is less than 28 weeks, is the 6-week schedule plus the 2 weeks of forgiveness, okay? If less than 28 weeks have lapsed since their prior injection, then you resume with their normal biannual injections. So on follow-up injection today, give her her injections as scheduled. If more than 28 weeks have lapsed since her prior injection, so she has stayed too long, 6 weeks have passed, 6 months have passed, another 2 weeks have passed, and we are now beyond 28 weeks, then you need to restart with all the LEN loading doses, which is 2 loading injections, 2 pills today, and 2 pills for the next day. Okay? And this is why we do this, is when you have missed your visit and 6 months have lapsed and an additional 2 weeks, you're now below the blue line. You're now at the point where the concentration of drug in your body is not sufficient to protect you from HIV, and we need to boost you back up. So you're almost beginning like with very low dose of CAB, and to get you up there, then we need to restart with your 2 injections and 4 pills in total over 2 days. Okay, so in the example we had, Amina got her injections 1 and 2. She got her injection on day 1 and completed her doses on April 2nd. She was scheduled to come on September 30th. She did not come, and she comes on October 8th. So this is 27 weeks. October 8th is 27 weeks from her first date. Okay, and so because it has not reached 28, we will resume with injections. But here is, so Amina, here is another scenario. She started LEN on April 1st, was scheduled to return on September 30th. She misses her appointment, and instead of coming on September 30th, comes on October 30th. So the hint here is that it's more than 28 weeks from her last injection. So here's our question. I think this might be easy. What should you do during Amina's visit on October 30? You're the provider. Give you a couple of seconds. I give you the hint. All right, let's see. The correct answer is we need to restart with the initiation regimen because it's more than 28 weeks since her last injection. Her last injection was April 1. We're now October 30th, and it's 30 weeks since her last injection. So we restart. And our restart is 2 injections on day 1 plus 2 pills on that day, and then an additional 2 pills for the next day. So here's the thing, this doesn't have to be very confusing for you, and you shouldn't feel very stressed about it, because within the toolkit, you will find that we have developed printable scheduling wheels, almost very similar to the ones we used for the ANC clinics, that can help you make decisions. When's the last injection? She's coming now. How much time has lapsed? What do we do? So you do not have to cram. Just use the wheel, or use the app, which we have also, mobile app that you could have on your phone, and you key in the dates, and it will help you make the decision, and you will know what you need to do for any client. So it shouldn't be stressful at all. But you need to know that when a client comes late, you make the decision. Do we start? Do we restart? Or do we resume? Okay. So say we're now after the final LEN injection and we are feeling protected and we have no more ongoing risk, then you need to know that once you have had your last injection, your final LEN injection, that LEN continues to provide protection for at least 6 months after the last injection. After that, then the drug levels continue to decline in the body, and we have what we call a tail, very similar to what was there for cabotegravir. So after the LEN injection, regardless of the injection type, whether it was your first injections, whether it's a follow-up injection, you have protection for 6 months, and after that, for 6 months after that, you get into this space which is a tail. You have drug levels that are not sufficient to protect you, but they're there in your body for 6 months. So what needs to happen at this time? You need to advise clients that they need to have quarterly visits. So it will be 2 more visits until it's a year since their last injection. So they need to come to clinic for monitoring, for retesting of HIV, for determining whether they have had whether they have had exposure, and so need PrEP, for instance, or managing their situations. But it is important for them to keep coming to the clinic for at least quarterly visits where we can do HIV retesting. Okay. And I want to hand this over to Heather Marie.
Thanks, Elizabeth. And now we move on to how do you transition between PrEP products? So this is one of the questions that I think many providers have, and it can be one of the biggest questions that clients also have. So what are the special considerations that need to be made for clients that are wishing to transition from using one PrEP product to another? So clients starting a particular PrEP product often may decide later on that actually they want to switch to another option. It could be because new options become available. It could be because when they actually take one option, they find that it doesn't fit with their lifestyle or their preferences. It could be that other things change. There can be a lot of reasons that somebody wants to change. And so considerations should be made for managing that switch between PrEP products that really pay attention to maintaining continuity of HIV protection. And this can mean that sometimes there's a small overlap in PrEP use between the different PrEP products. So for example, because a new PrEP product will not begin, and this is because a new PrEP product will not necessarily begin to protect you immediately. It may need to be started prior to the other PrEP product stopping to maintain that protection. Next slide. So a question for everybody in the audience again, if Amina is already using oral PrEP, and we know this from when she presented, How would you manage her transition from oral PrEP to lenacapavir? Should she stop taking oral PrEP the day before starting LEN? Should she stop taking oral PrEP the day that she starts LEN? Continue taking oral PrEP for 2 days of LEN initiation, or continue taking oral PrEP for 1 week after starting lenacapavir? And so I will give you all just maybe 20 more seconds. I can see that lots of people are getting in and answering quite quickly. Okay, so I can see here that actually there is quite a diversity of responses to this one. The correct answer is continue taking oral PrEP for 2 days after starting lenacapavir. So congratulations to almost half of you, I think, answered this one correctly. Well done. So when somebody is switching, when Amina or others are switching from oral PrEP to lenacapavir, they should continue using that TDF-based oral PrEP throughout both days of receiving the initiation regimen. So on the day that they have their first injection for lenacapavir and oral pills, and the second day of taking those oral pills. This allows them to maintain that protection, so we know that they have sufficient lenacapavir in their body for protection. And so clients should continue, so as I mentioned, clients should continue using TDF-based oral PrEP throughout both of those days. And this is what it looks like to show that kind of overlap. So they continue as they've been using oral PrEP up until the day that they come into the injection, still continue to use oral PrEP on that first day that they got the injection and took the oral loading dose for lenacapavir, and on the second day they should also take their oral PrEP plus their lenacapavir. And this does probably provide a little bit of a little bit extra protection as well, just to make sure that that lenacapavir is at sufficient concentrations in the body to provide protection. For those switching from cabotegravir, or long-acting injectable cabotegravir to lenacapavir, and this is going to be the case in some countries now, it will depend a little bit on whether they're switching after their first cabotegravir injection, so they've only had 1 cabotegravir injection, or if they're switching after taking long-acting injectable cabotegravir for a longer period of time. So, next slide. So actually, it's easier than it sounds. The best advice is really to look at when the client is due for their next injection for cabotegravir. They can transition at that time. So rather than getting cabotegravir at their next follow-up injection, they would get lenacapavir instead. That's the easy secret to remember. So irrespective of whether their last injection was an initiation injection or it was a follow-up injection, this advice will work. So clients who started with their, clients should start their lenacapavir initiation regimen 1 month after the injection, their initiation injection for cabotegravir. So it's cabotegravir, their first injection for cabotegravir. They've decided that actually they want lenacapavir for whatever reason, that after 1 month, they get an injection for lenacapavir and they start, and they have their oral loading doses. Really simple. So instead of getting cabotegravir, they get lenacapavir. If it was their initiation injection 2, so they've at least had 2 cabotegravir injections, or it was a follow-up injection for cabotegravir, then they're due usually for their next cabotegravir injection 2 months later. So instead, again, of getting cabotegravir at their next scheduled injection, they would get lenacapavir and have the initiation doses. So really, again, I feel like that made it more complicated. The simple advice is administer the lenacapavir initiation at their next scheduled injection. And so there is a downloadable resource included in this toolkit that will help to explain and at a glance that transition between products. And I feel like this is one of the things that is going to be one of the questions that people have the most. Over to you, Elizabeth.
Thank you. Thank you, Heather Marie. So, So that what we have done this afternoon is give you a flavor of what the training content looks like and how you can use it once you access it, and what you will find there, and how you can use it in your day-to-day practice. But you can take this material also and adapt it. I can imagine. So first of all its resources are available on this link, and you can use the QR code and you will find links to these lessons. We also have an open Google Drive folder that hosts all classroom-based material. So like all the job aids you will find. You will find also that we have change some of this material in the digital learning into PowerPoint slides that you can take and edit and adapt to fit your country's needs. And you can use that for a classroom-based learning, for hybrid training, whichever approach you would like to take as a country or as a program. And so please contact us and we'll be able to give you this material. But I want to tell you that coming soon, really what is exciting us is we have been able to revise this material again so that if you just want to learn about LEN, because you probably know all there is to know about oral PrEP. You've been doing oral PrEP for the longest time and you have trained and your providers know, and maybe you do not have a ring in your country or you do not have TAB and you're really just interested in understanding Lenacapavir. Very soon we're creating a Lenacapavir focused learning pathway. So you can just come and learn about Lenacapavir just by itself. Right now, the training module has all the methods, but it is possible that you do not want to learn about all the methods. So just watch this space and very soon we will have a LEN-focused learning pathway. And so you could choose, a country would decide to adapt the material, get the PowerPoint slides, and want to adapt that material based on many things, like what are the products available in your country? If you don't have all the products, then you can remove some of the content. Maybe eligibility criteria may be different depending on different countries. So feel free to adapt that to fit what's in your country. And also decide what's the best training approach that you could use. Do you want to do virtual? Do you want to use in-person training or hybrid training? That would be fine. Do you want to print the scheduling wheels and use them? Or as a country, do you want people to use their mobile phones and use an app? So all those options are available for you using this training toolkit. And please do feel free to contact us and we'll be able to support you in how you can utilize this material. Additionally, a country may want to also host the training content on their digital platform. And so that your providers can then go into and do the training on a digital platform and earn CPD points or CMEs. So we do have SCOM files that we could share with you and then you can adapt the material also to fit your country requirements, and they can fit in into your digital planning training platform for the Ministry of Health providers. So please feel free to reach out to WHO and Jhpiego, and we'll be able to support this. So with that, I want to thank you so much and hand it over to Michelle to moderate a Q&A.
Thanks so much, Elizabeth, and thanks, Heather Marie. This has been a very lively Q&A, and Elizabeth, if you could put your video on it as well, because I'm going to direct a number of questions in the Q&A to both Heather Marie and yourself. And just while we open up for the Q&A, I want to say I've been doing my best to rapidly answer questions as they come through so that we don't overwhelm Heather Marie and Elizabeth. But there are a few questions that I'm going to just raise directly to Heather Marie and Elizabeth. And while I'm raising these, if Heather Marie and Elizabeth could take a look at some of the questions that maybe they want to answer from their own expertise. So I'm just going to start really with one of the easier, what I would say, more direct questions to answer. And I'm not saying it's necessarily easy, but it's important to understand the dosing regimen for Lenacapavir and why this is the dosing regimen. So Heather Marie, I'm going to ask, instead of directing a question directly, could you just please go over the dosing regimen, why it is like it is? And I want to just draw attention on a question that came from a number of our participants, is why are the injections separated into 2 injections and it's not just 1 injection? So over to you, Heather Marie.
Thanks, Michelle. And thanks to everybody who asked these questions. So we do have, when you're starting Lenacapavir or when somebody is starting Lenacapavir, it's 2 1.5 ml injections. And those are administered typically at the moment either side of the stomach. Now, they're subcutaneous. So the volume of injection is actually quite large. To administer that in 1 injection, so 1 3 ml injection subcutaneously, would just be not a good idea. It's a very, very large volume of injection. So that would not, that's why we don't do that. And it's kind of similar for the oral pills as well, because of, you don't want your oral pill to be so large that somebody can't easily take it. And we know that this has been a problem with even just TDF-based oral PrEP, that some people really do have difficulty swallowing the pill. And that, in some cases, for example, TAF is preferred because it's a smaller pill. So part of it is to do with just the size and the volume, and then the potential side effects and things that you could get from just having, so much all at once. So from the volume, not from the drug. And so yes, 2 injections either side of the stomach, and they're administered at the same time. And then 2 pills on the first day. Those are important because it allows the person to reach protection very quickly, and 2 pills on the second day, which allows people to the durability of the protection. So maintain that oral protection until you're protected by the injection. So that injection protection kicks in about 3 to 4 weeks after the initial injection. Having everything all on the same day is not advisable because it could cause, it would be difficult to absorb for the body, and it could cause gastrointestinal upset. So have it on the second day. Don't take all pills on the first day.
Then Heather Marie, just while I have you, there are some very specific questions here, and I do want to echo Heather Marie's thanks to everyone who has asked these questions and who has joined and remained on the line. We have over 900 participants right now, which I've never seen so many on a WHO webinar. So this is really wonderful. And thanks, like Heather Marie said, for all your reactions. It helps, it makes the webinar feel even that much more interactive. I'm going to ask you, Heather Marie, a question from Jane Mooley about when switching from Cab-LA to LEN, is there a need for the oral loading dose of LEN, or can someone go directly to the LEN injection?
So no, the oral loading dose of Lenacapavir is still required, and it's again required specifically for that reason, to allow LEN to reach protective levels as soon as possible. We know with cabotegravir that there is a little bit of for want of a better word, wiggle room if cabotegravir is provided on time, that it will provide some protection. It's not, but if you're waiting, your cab injection is provided on time, but you're not protected for lenacapavir for 3 to 4 weeks, you may dip below those protective levels of cabotegravir before your lenacapavir is high enough. So it's really just making sure that you are protected no matter what happens.
So thank you, Heather Marie. Elizabeth, I'm going to take a question for you on the policy side here. And what can policymakers do to ensure that this toolkit is widely available, widely used and available, and that physicians are sufficiently informed about PrEP use?
One is attending a webinar like this, so you get to learn that it exists. But I think there are a couple of things. Is if, for instance, the country has a digital learning platform, this could be hosted on your digital learning platform, and you could make it attractive by assigning CPD points to this. And so health workers are continuously looking for CPD points, and this would be an easy way to earn your points for registration. But I think also the material is quite adaptable for countries, and governments, as we are beginning to think about rolling out LEN, this could become your basis, your starting point for beginning to introduce lenacapavir. And so you would train, your TOTs, and they go through the material and adapt it. And then the TOTs would cascade this to other providers and draw people also to where this material is, and they would be able to use it. But I do think that it is easy, available, ready to use. And so policymakers should really take advantage of it and run with it.
So Elizabeth, while I have you, and since you're from Kenya, and Nguri is also from Kenya, I'm going to ask you a question that's come from Dr. Kenneth Nguri, which says, it's not clear to me why those switching from oral PrEP will still need to continue on oral PrEP for 2 days, considering that LEN initiation regimen is sufficient in all their cases.
Oh, I see. Okay, Dr. Nguri, how are you? So so this is the reason why we are covering a period. There's a period between where you drop off oral PrEP and when you do the injection, how long it takes for that injection to give you sufficient protection. So if you have been on oral PrEP, and oral PrEP is supposed to be a daily dose, if you're going to initiate LEN, LEN does not immediately pick up for you. It will take 2 days, a day or two. On the second day, you then have sufficient protection. So between the point where you get your LEN injection and the point where you get your protection, then we need to cover those 2 days. And that's why we say continue with the oral PrEP for an additional 2 days. And that would be true also for any other method, for most of, well, is there any other method? I think for the DVR also. But there is a job aid that we could use that will help you make this seamless and easier to understand. And then Michelle, if you allow me to answer, just to add on to a question regarding like how long do you allow missed appointments? I think there is room also for, and we didn't cover it here, that participants could also have weekly dosing. If you know in advance that you're supposed to come to the clinic September 10th and you're not available to come in until, I don't know, November or December 1, and you have a couple of weeks there, you know in advance, if depending on your national guidelines, countries could decide to allow weekly dosing of oral lenacapavir. So you get a weekly pill to cover those weeks when you're away until you can come back in and resume your injection. So it's an option I'm throwing out there because I see a question here about how long you can allow missed appointments. There is an option for weekly dosing. If you know you're going to miss your pills, your injection time, but it also has to be something that your national guidelines have approved. Thanks.
So now I'm going to move to, there's a number of questions on testing. And I really put it to both of you. Actually, I'll start with Heather Marie, who worked with, who was one of the key partners in the testing recommendation for rapid diagnostic tests for Lenacapavir. There's a number of questions about missing an acute infection at that first visit with a rapid diagnostic test. And then there's also quite a number of questions from colleagues, and I'm naming names because I can see who's on here. I think others can too. So Chris Okolo from FHI 360 has asked, has a number of colleagues from Kenya, South Africa, to understand what about missing acute HIV infections with that rapid diagnostic test? And is it recommended to come at 1 month for another test, or is it not recommended? What is the testing regimen? And then Elizabeth, I'll give you a chance to add in as well with your experience. Over to you, Heather Marie.
Michelle, who also was leading the process, please also jump in with anything additional. So with WHO, there was a recommendation made about the use of rapid diagnostic tests, and that these can be used for long-acting injectable pre-exposure prophylaxis. So basically, what we encourage is that countries use their national testing algorithm of quality assured rapid diagnostic tests to perform the testing on initiation and also follow-up testing. There's a couple of things. Countries may decide to have more frequent testing, and this is something that was discussed at length. One thing to remember is that we absolutely, if somebody is suspected of acute HIV infection, particularly with something like lenacapavir or cabotegravir, and there is a likely exposure within that time, so they have the signs and symptoms of acute HIV infection and a likely exposure, initiating them on lenacapavir or cabotegravir for that matter may not be the best option for that person. There may be other options that would be better. If it is just that somebody could have acute HIV infection, there are no signs and symptoms of this, nothing to suggest. Absolutely, there could be undiagnosed HIV infections, and this can be the case for all, for initiating any type of PrEP. This was discussed at length. We did have, a lot of discussion about whether a mid injection HIV test could be useful. So could it be useful at 1 month? Could it be useful at 3 months? And a few of the considerations, and I would love other people to jump in, but a few of the considerations and the reason that we did not recommend this, though we acknowledge countries may decide to do this, was that one of the huge advantages to a long-acting injectable like lenacapavir is the infrequency of visits and how much the additional cost of recalling clients in between injections, the additional cost to the client, and also the message that may also send about whether lenacapavir works. We had 2 breakthrough infections in across both Purpose 1 and Purpose 2. Both occurred in Purpose 2. And those 2 infections would not necessarily have been detected with a 1 month injection. And so really, countries and providers need to weigh up the additional costs and disadvantages of having additional testing requirements with the advantage of the very rare case of detecting an HIV, a breakthrough or a undetected HIV infection. So they would be detected at that 6-month period.
Thanks, Heather Marie. Thank you for that. Elizabeth, do you have anything to add to that?
Well, and just that the PCR or NAT testing is really, really expensive and hard to come by, and it would just make programming so difficult to do. And this is one of the things that you actually weigh. What's the benefit? What's the risk? And that I would like to think that the risk is so much smaller compared to the greater benefit you would have by availing this product to so many people in a cost-effective and accessible manner. So, but that said, I mean, countries should actually go on and look for what are they identifying HIV infections among people using LEN, and continue to do that kind of surveillance as the program rolls out.
Michelle, there was also a couple of questions on adverse events and side effects of lenacapavir, which I thought might be good to address.
I want to just jump in with one piece
sure.
on testing before you move to side effects, because and I'm just Loretta Nyabe and Purvi Shaw. Thank you for your questions about HIV testing at 28 weeks, or rather for second visits. I want to just confirm that the testing regimen for using lenacapavir is testing at initiation. And as Heather Marie described, and as was shared in the chat, if people or if countries require a test in between initiations, if people want to test or use a self-test in between taking their injections, that is not contraindicated to take a test. It is just, as Heather Marie described in discussion, to keep testing simplified, to keep the product accessible. The concurrence from the guideline development group was that testing should be recommended at each injection. So just with that said, and this was as Purvi, I hope I'm answering your question, and I know you'll follow up if I don't. When a person comes in for their second injection, before receiving that second injection, if they come in at 26 weeks, at 24 weeks, at 28 weeks, if they come late, they still need an HIV test before getting their next injection. And that continues through the cycle of receiving the injections. So I just wanted to end on that piece, Heather Marie. And then maybe just to comment to Elizabeth on the window periods. You're not, by having a rapid diagnostic test or fourth gen or a NAT test may detect an acute HIV infection within 7 days. However, there's been research done showing that the risk of a false positive with a NAT or PCR is much higher with an RDT. And as Elizabeth very accurately described, the cost of doing a PCR is high. And also the chance of getting that result back in time is also very low. We've heard reported in some countries in East and Southern Africa, it can take up to 6 weeks to receive the results. And so from a cost effectiveness perspective, and looking at the risks versus the harms, meaning the harms of a delayed diagnosis, delayed waiting for a test result, and the increased and improved sensitivity and specificity of rapid diagnostic tests. That is why WHO recommends rapid diagnostic tests for initiating lenacapavir and cabotegravir. But Heather Marie, I want to go back to you now on the side effects, because that was also a very common question in the chat.
So I'll go quickly, and please, Elizabeth, also jump in with other things. But the most common side effect that was reported across both Purpose 1 and Purpose 2 was injection site reactions. And so it was probably between 3/4 and 2/5, so 70, 80 at least %. Yeah, 70 to 80% of participants who were receiving lenacapavir reported injection site reactions. And so these could include redness, pain, bruising, or nodule formation. So the formation of hard nodules at the site of injection. The frequency and the severity of these tended to decrease over time. So as somebody got more injections, the injection site reactions decreased. They rarely, at least within the trials, led people to discontinue. So it was rare that an injection site reaction was the reason that somebody stopped taking lenacapavir. The other thing that's probably worth noting with this is that those injection site reactions, of course, can be treated symptomatically. So, pain relievers, for example, so paracetamol, for example, things like that to relieve those injections. And I know that somebody did have a question specifically about the nodules, and not everybody gets nodules. So these vary between people. It can also vary between injection. And the nodules can last for a short period of time, or they can last for several months. So this is something that is, it's something that a client may feel at the injection site. And so it may be something that particularly maybe it's a lot of these, like with everything, if somebody knows about the potential adverse events or side effects, it's much easier to manage because they're aware that this could happen. I think it could be more disturbing if they're not aware that this could happen.
Thanks so much, Heather Marie. And Elizabeth, just before I move to another question that I might just randomly ask you, is there something you want to address, maybe just from this conversation we're having?
I see questions about where you can administer. So you're going to administer 2 injections on the abdomen, or could use the thighs. So at the abdomen is about 5 centimeters from your navel on each side. And then you could also administer on the thigh. So you could take turns, and this early year you're doing the abdomen, the next 6 months you could do in the thighs and things like that to avert, to hopefully manage the nodule situation if it's happening. But there's a question about whether you could do the injections on the deltoid. I think that has not been evaluated yet and is currently not a recommendation.
So thanks, Elizabeth. I wanted to just pull up one question that's just because I'm sure other people are thinking it as well. And this is a question and I'll ask you, Elizabeth. Are there specific indications for doing post-injection laboratory tests, creatinine, liver enzymes, et cetera, for certain populations with known comorbidities? For example, someone known to have some form of hepatic or renal impairment. And the question was specifically for the initiation dose.
So remember that our PrEP clients are whole clients, and they have all their lives going on around them. And having a PrEP injection is just one small bit of the whole business of their lives. So a client coming before you and they are hypertensive or are diabetic or have whatever other conditions, as you examine as a clinician, you are bound to manage that client as you would any other client who was not even coming for PrEP. So if you're going to do a mental health assessment, do a mental health assessment. If you're going to do tests to determine renal status, you're going to do them because this is a whole client, not necessarily because they're doing PrEP. So what we try to distinguish is where, for instance, for oral PrEP, we were concerned about people with renal disease because of what PrEP would do to their, oral PrEP may do to their kidneys. And so you want to be sure that this client is well and healthy to be able to receive oral PrEP. But for LEN, there are no comorbidities that would contraindicate you from using LEN. But if that client coming before you has some underlying condition, please go ahead and examine them and manage them for that as well, because they're a whole client. Okay, so and whether it's at an initiation visit or follow-up visit, manage that client as a whole client, including all the things they have, including family planning or gender affirming hormones, whatever else their need is, you would want to address that.
So Elizabeth, also just to clarify as well, for somebody without comorbidities, are there other laboratory tests that are recommended for somebody initiating lenacapavir?
For lenacapavir, you need the HIV test. I think with the HIV test, you are good to go if you have no other conditions with you.
And can you just say that again? Because I get this question all the time. So what tests do you need before initiating lenacapavir?
You just need a negative HIV test results on the day of initiation. And it will be a rapid HIV test result based on your national algorithm. And that's it. But it's really not complicated, that's all.
No, and thank you for saying that. And I think we all have to just keep repeating that. You know, we've really come a long way in our work with PrEP and knowing the tests that are needed and what we need to do for HIV prevention. This has been a new space for a number of us on this call and with our videos on, listening in, the evolution of simplifying and demedicalizing ARV-based HIV prevention. I'm going to take a moment to just read out a comment from Nicolette Naidu from VITS RHI about NAT testing at initiation. So Nicolette, thank you for sharing your experience from the Catalyst study, and I've put this in the chat so others can see it as well. Nikki added that our experience at VITS from the Catalyst study only yielded less than 1% of undetectable HIV cases out of more than 1,200 tests / individuals consenting for testing. This was for CAB and the risk seems low. So I'm sharing this not as an absolute, but as a real experience of using NAT testing and part of the debate / argument for why we can rely on rapid diagnostic tests. Heather Marie, I'm going to go to you for a question about price, availability, and generics, wearing your UNAIDS and WHO hats. If you could just share a bit on recent events, just on what is known about price and availability of Lenacapavir to share with the group. Over to you, Heather Marie.
So there has been a lot of activity, I would say, in the last month or two around access and availability. So you may be aware, many people on this call, that the Global Fund, for example, has identified 9 early adopter countries that they are supporting with Lenacapavir introduction by early 2026. In addition to this, we know that PEPFAR is also supporting a number of countries, and off the top of my head, I've forgotten how many, with Lenacapavir introduction, and I believe that's also planned for early 2026. At the moment, the only product that is available is the Gilead product. So Gilead is the manufacturer and supplying these early initiator countries. However, and thank you, it's 10 countries from PEPFAR. However, we, in the last month, both the Gates Foundation and UNITAID have made announcements about agreements with 2 generic manufacturers separately on reaching a price for the injectable component of Lenacapavir of $40, which is, I think, probably lower than most people had really anticipated before these generics are available. And so the generics are likely to become available from the end of 2026 or early 2027. Of course, we're all hoping for generic availability much sooner. Now, there are 120 low and middle income countries that are covered by the generic licensing agreement. There are additional countries, unfortunately, who are not benefiting from that licensing agreement. And these include Brazil, for example, Malaysia, but many, many others. And some of those countries we know are entering into negotiations with Gilead separately around this. UNAIDS and WHO has been very active and vocal about the importance of equity and low pricing for Lenacapavir for countries. And so this is something that we continue to advocate for. Michelle has also been involved in a lot of these discussions and may want to add more.
No, nothing to add from my side. One thing just to add, and just noting, Tiki added in the chat that PEPFAR has also come onto the scene and will be supporting Lenacapavir rollout in 10 countries. I don't know if those countries are publicly announced yet, so we'll not share them on this chat, but there are a number of overlap with countries in for the Global Fund, 9 countries in Afro. I'm going to take a question on that over to Elizabeth. And this is a question from a close colleague from Brazil, Inês Dourado. And Inês is asking, is there guidance on how to explain and motivate clients on the importance of taking those 2 pills in the next day?
Well, that's an interesting one. We do not know whether people will take it or not, but this is what I think, is that people have been struggling really hard to take a pill every day for a month and then come back and give a refill, and then 3 months and keep saying, take your pill. And providers and programs have learned and have come up with messages for motivating clients to take their pills every day. Whether it's been successful, partially successful, perhaps not very successful. But we could use those learnings. And the message would be, you only need to take this once tomorrow. It's just this. You have been doing oral PrEP and you've been taking them for so long. Just take this to tomorrow. And that's it. I will not ask you to take any other pills if you come for your visits on time. And I think that would be motivation enough to get clients to want to take that additional pill. And to say, and once you do this, you're covered. You're covered for the next 6 months. I think is highly motivating for individuals to want to take the next pill. But as we roll out, we're going to see what it's going to look like in programs, but I'm highly optimistic. Yeah.
Thanks so much, Elizabeth. And Heather Marie, before asking you one of the questions, I can see that you're answering some questions in the chat. So just wanted to ask if there's something you wanted to answer verbally, or do you rather I toss you a softball?
There was just one, I think I saw it a couple of times, and we're so blown away by how many questions you're all asking, by the way. We're not going to get to all of them, but hopefully we've gotten to most of them. But I did notice a question around drug resistance, and it's something that we haven't addressed in this webinar, but we often mention at least. And I'll just quickly noting that we've only got a couple of minutes talk about that. So there were 2 breakthrough infections that were reported in the primary studies or papers for Purpose 2. There were no breakthrough infections in Purpose 1. And both of those 2 breakthrough infections did show capsid inhibitor resistance, so resistance to lenacapavir. It's not surprising considering these people had lenacapavir in their system. One of the things perhaps that is reassuring is that lenacapavir is a first-in-class ARB, and it is not widely used for treatment. So it has been approved in the US, for example, for use in highly treatment experienced individuals, but it is not widely used at the moment. So the reassuring thing is that the current public health impact of drug resistance is currently limited. However, what we would say is that ongoing surveillance is needed, and particularly anybody who seroconverts after having been exposed to lenacapavir, this is where you would want to make sure that the surveillance, not only are you capturing that somebody has seroconverted after having lenacapavir, and perhaps they had lenacapavir, their last injection was up to a year ago, but also looking for any resistance after that time. So that's the piece of advice I would probably say.
Thanks, Heather Marie. And then I'll just, we only have 2 minutes, and I just want to go back to Heather Marie and Elizabeth because I've gotten so, do we have somebody closing out the session that I should be handing over to?
You could close it.
I can close it. Okay, well then I'm going to close it, but I'm going to take the moderator's prerogative and have the last word and address lenacapavir use during pregnancy and breastfeeding. This is a subject, a topic area very close to my heart. I have been a pregnant and breastfeeding person at different times in my life. And I know, and anyone on this call who has been or will be a pregnant and breastfeeding woman knows that there's a lot of things you can't do. And one thing that we can do and we should do is be able to protect ourselves from acquiring HIV and any other STI that is or possibly at risk of acquiring. Unfortunately, we have data to prove that pregnancy and breastfeeding periods, women are at an increased risk of acquiring HIV during the pregnancy and breastfeeding. The reasons for that have to do with social situations, with the changes in our bodies. But we are really grateful to have data from these studies that show that lenacapavir use is safe during the pregnancy and breastfeeding periods. We still need more follow-up data, but women who are become pregnant while taking lenacapavir should be encouraged to remain on lenacapavir if they see a need to continue to protect themselves from HIV. A woman may initiate lenacapavir when she's already pregnant, if in a discussion with her provider, if she sees a need or has a desire to protect herself from HIV. And I just want to end on that note, that this is the product for people who will benefit from PrEP. And then it's up to the individual to decide whether or not they may benefit from PrEP. And I want to thank everyone on this call, the providers, the community. I thank you to our colleagues from the Ministry of Health in Mozambique. Pedro Antonio, I saw you in the chat, our WHO colleague in Mozambique as well, Leonid Joaquin. And we are now at time. So in respect to all of you and your time, I'm going to close out this meeting. But the biggest thanks to our colleagues at Jhpiego, Tiggy, Elizabeth, Katie Journey, Jason Reed, Molly, and I'm sure I've forgotten somebody, and Heather Marie for making this session happen. Really, this is why it took a village to bring this session together and bring you all together. So the biggest thanks to all of you. Thank you. And with that, class dismissed. Hope to see you again.